I see our roles as architects of healthcare reimagined.
You need to be a faster problem finder.
So we're not talking 6, 9, 12, 18 months. It's here today.
We've got to build capabilities that do not burn out the physician or the caregiver workforce.
It's got to be a de-risk model, and therefore you default to buy.
All care will be conversational.
You cannot transform how you undertake process without digital.
Hello, everyone, and welcome to this episode of The Transformation, a podcast from Euphonia, where we discuss the changes that are happening in healthcare enabled by the amazing progress in technology. I'm Nick Pennington. I'm the CEO and founder of Euphonia. Today, we're going to be talking to the architects, the people behind how digital changes healthcare, the Chief Information and Digital Officers. We have two amazing individuals who run large healthcare systems on either side of the Atlantic. David Walliker is from Manchester and Randy Gaboriault is from Delaware at ChristianaCare. We're going to be discussing how they approach technology, how they think about change, and where the opportunities are for the future. It should be a great conversation. Welcome, David and Randy. I want to just start off by asking you to introduce yourselves and, give a bit of context to the people listening about what your role is.
Yeah, of course. So, and thank you for inviting me, Nick. So I'm CDIO, so Chief Digital and Information Officer at Manchester University Hospital. So traditional CDIO role in the sort of concept of all things solution data for operational and research, innovation, transformation type services, but unusual in the scale, certainly in England, of the organisation. So Manchester University Hospitals is the biggest NHS trust in the country. So we're 10 hospitals, an ever-growing number of staff, 33,500 staff, 10 hospitals, biggest hospital in England, largest children's hospital in Europe, large provider of tertiary care and specialist care. And I also have a role at Manchester University.
Great, thanks. And Randy, for you, is it the same role?
It's wonderful. It resonates because we literally have the same title. However, probably the very different contexts. And a simple example is a differentiating point here is that our investments in technology need to drive a return on investment for our platform of delivering clinical services. And so there's no other member from a structure that sort of controls or operates or says this, invest here, invest here. It's driven by us. And then here in the US, we're a mid-Atlantic based system covering 4 states. And the interesting thing is across those 4 states, the context and the environment, the payer community, the clinical platforms, all are very different from each other, including, I'll draw one example. We have clinical services in the state of Maryland, and the state of Maryland is unique in the United States in the fact that it has a Medicare waiver for which it can deliver care, but it gets reimbursed very much like a UK enterprise. It gets a global budget and says, here's what we expect, how many hospitalizations you're going to have. And if you have one extra, you have to pay. And if you have, and if we send you one less, then there's perceivably benefit. But we have to absorb the downside risk here under that model. So,
and I guess there's no doubt that what we're going to end up talking about is money and finances and how do you deliver care. Can I just check, Randy, one other thing about your role, I understand you're also responsible, you said about investment, but you're actually responsible for investments on behalf of the hospital as a whole. Is that right?
Yes. And we have an investment portfolio, and we've been doing this for several years. And it allows us in several ways to, one, protect conceivably when we make an investment, the influence in terms of we're getting our problems sort of on the radar of these companies in ways that when we see firms that we think we want to assist in capitalizing those firms, it's because we see a clinical or some form of a administrative benefit to running those platforms. But we hold ourselves to the model is that we may at first be a commercial client of one of these systems. And secondarily, we may ask ourselves, do we want to invest? Because sometimes the product is great, but the valuations may be very frothy. And so we've got to be able to sort of think about the return on those investments as well.
And that is the only real difference, I think, Randy, from from where you've explained to ours. So although the NHS is one, the only thing that unifies the NHS is the word NHS. So each trust is a sort of legal entity in its own right. So we have sovereign ability to make a decision on what we invest in and how we invest it, but obviously to some form of national coordination of tactics or standards, etc. The bit that differentiates from what you were articulating is we have the same ambition in the commercial capital investment piece, but we don't have the right or ability to make cash investments in those areas because we're funded by the Exchequer. So all our direct funding, which is the same challenge with regards to, in effect, it's a block contract. So if we do more, we've got to be more productive to absorb it in, is for direct patient care. And so there's a wonderful challenge, I think, here, this side, in our model with how do we actually invest in that innovation at scale rather than wait for the turnkey solutions, by which time they're probably priced out of our pay point anyway. So I think that's one of the conflicts in the UK market.
That's an interesting one. And for us, too, part of it is thinking about commercial clinical differentiation that you can establish with those investments. And, do we want to be a laggard? Do you want to be a leading edge innovator? Do you want to be a kind of early majority? So thinking about any particular given tool and the context in which it helps us execute the ambitions of our strategic plan as an organization.
Can I just bring it back to you as individuals? I mean, I guess as you both went into the profession, the role of the CDIO was not as significant as it is today. Is that fair to say? How have you seen things evolve?
It's always been that significant to me, Nick.
Well, I guess I mean in terms of the ability to fundamentally change and be responsible for care. Again, I'm not passing any judgment, but I guess 20 years ago, people might have seen the CDIO role as the person that makes sure that the early stage EHR system is in place, the other IT is working. Now we've titled this episode, The Digital Architects. You are integral to the delivery of healthcare, as important as the people actually doing the surgery, I think, in many ways. Have you felt that change happen, David, over your career?
Yeah, for sure. I mean, I've been in the NHS now for 22 years, and I was 10 years private sector before healthcare. So I came in very naive to what I thought the challenges were and then fell in love with it and still here 22 years later. To your point with regards to the role, Nick, 100%. So it has gone from a provider of services to integral to how the service is delivered. There are certain things. 22 years ago, the IT department would have been a back office. Back office doesn't exist anymore because it's too integral to the delivery of safe and effective care. And it's not now a nice to have. But I think the thing that we hold on to, or at least I do sort of drive from a vision perspective, is that logic of if all technology that exists when you're born is normal, all technology that's invented before you're 18 is a career opportunity. And if you follow it right the way through, all technology invented after 70 is evil and should be turned off if you listen to my father. But, let's hold on to the all technology that exists when you're born is normal. We now live in an age where technology has been normalized for the last 26 years, for all intents and purposes. We now live in an internet age. And that's really important because that means we've got resident doctors coming through training now who have known nothing but what is now normal. And the technology stacks, because the diagnostics and the therapeutics hasn't massively moved on. I mean, arguably it's not materially massively different. It's how we deliver care that now is underpinned by effective use of technology. And it's expected and it's demanded. And if we don't keep at the front of that curve, and other hospitals do, they're just going to go and work somewhere else. And we need the best people to come work here. So now it becomes less of a wires, boxes, revenue type conversations and much more. This is integral. We've got a motto within our trust of sort of clinically led, operationally delivered and digitally enabled. The three things, it's digital is a golden thread. You cannot transform how you undertake process without digital. Otherwise, if you disinvolve us at the end, you're just going to digitize a bad process quicker. And I think that whole mentality shift has moved over 22 years. It's moved dramatically in the last 10. And then I think since COVID, since the pandemic, now that actually patient expectation has shifted the dial, it's really ratcheted up to the next gear. So I think it's unrecognizable role now to 5 years ago, and 5 years ago, unrecognizable to 5 years before that. And to when I came, it's not the same job.
Well, I think back to when I entered the industry in a way, it was kind of the role of IT was fix my printer. And then it moved to fix my process. And then it went on to digitize my business. and enable my strategy as sort of those pillars. But it has really changed. And I really like the framing that David talked about on those horizons of sort of technology innovations and their metabolization into an organization to again drive strategy. And so now, having sat in the back office, now this role sits at the executive table and becomes really the core enabler of differentiating what you do from others, both on the realm of the patient experience, mid-rev cycle, strategies, all the way through the provider experience. So thinking about and being able to sort of build on those with contemporary technology. But going back to that last point, being able to sort of create competitive advantage in this. I look at our digital strategy sort of as two wings. There's one which is digitize my internal processes, help make my business more effective, help make me more efficient. And then there's the second realm, which is digitize my product. And now that is thinking about healthcare being delivered in a virtual fashion and all the components that come with that. And so if you can sort of reposition the product, rebuild, what does a distribution network look like in an analog world of healthcare? And what does a distribution network for your product look like in a digital world, as I think and seek to digitize my product offering? And so we're doing that through the use of virtual capabilities and building things like a Center for Virtual Health, like we've built, to basically arm the organization with that. And also not treat virtual and those other components so special. They're just another platform. They're just another platform. And we have to be facile. But if there's a capability coming to market, we need to invest and ensure that we are facile and capable of executing and doing what those technologies can do before it becomes majority users in the market where you no longer are competitively differentiated.
It feels like technology is moving incredibly quickly. As we're recording this, we've just come through a really pretty tumultuous week on the stock markets in terms of people's, understanding of software and the value of software and the ability to, accelerate the development of software. Randy, in that context, like, where are the opportunities? What's the thing that's front of mind for you today in kind of early 2026?
Agentic AI is first and foremost, I think, the place where we see a lot of short-term impact to help alleviate decisions, to help assist sort of the challenges that we have with our workforce, to make smarter decisions that are informed decisions. I joke and say, the software and the tools should be able to analytically assist every decision that takes place in our health system, including how much chicken should we order for our facilities for Tuesday the 18th if it's forecast to rain. I mean, just like such detail to help drive super high quality, high performance decisions. So that's in the agentic space. Conversational is a lot of value, and I can share an example, in our conversation today around what we're doing with conversational from that standpoint. But we also think, what we want to do is use technology also we want to abstract away complexity, and we want to basically return agency back to the patients. And unfortunately, so that's something we really look at is, can we drive with agentic technology? Can we return agency to the patients by giving them control over whatever process they're in from that perspective? And from that standpoint, we think about, as you're building these tools, how can we find the problems and opportunities faster than others? Because everybody has the same amount, in theory, has the money to throw at the solution, but how can we be faster at finding the opportunity and can outperform the competitive environment by being faster problem finders and faster problem investors?
And I guess, David, the competitive environment is slightly different. I mean, you're facing quite a lot of national solutions. Where are you seeing the space to kind of move and to be at the front of technology?
So I agree with Randy with regards to the agentic piece. Conversational AI for us is really important because whichever way we sort of look at the numbers, the data would indicate we're less productive now than we were at the beginning of the pandemic. And I think the reasons for that are multifactorial, very complicated, etc. I don't think there's an easy linear piece of this. I think some people will say, it's because we put large electronic patient records in and we've made productivity down. I would counter that with, I think that lack of productivity has always been there, but actually the effective EHRs now shines a light on it as opposed to it's because of it. But I think the agentic is number one. Then the conversational sort of ambient thing, because that's just going to be game changing for us, certainly. And probably not in the areas we think it is. I think it's probably going to be more in sort of emergency room and nursing, potentially, than outpatients, but it's going to be large across all of them. From that sort of patient piece, I think it's fascinating, isn't it? Because from an NHS perspective, so we've got a patient app that's connected to our EHR that we have, pushing, it's going up sort of double 1,000 digits per month, but any given time, 660,000 connected users on there. Nationally, we've got the NHS app as a single front door to the NHS. And of course, we should have that because we are all patients of multiple services here. So you can't have 16 apps on your phone. It's not compatible. But the national driver is much more around alerts, notifications, cancels appointments, and sort of scheduling. Whereas our application is much more about your EHR in your pocket and ways that we can empower the patient to contribute to that. And I think, so we need to find that sort of path. And the two aren't mutually exclusive, Nick, is the bottom line. And we will, and are interfacing the two up. I think the game changer for us now is going to be the ingestion via that sort of application of more consumer-based wearable technology to enable us to do these sort of the real model of care changes that are required when we talk about the sort of hospital at home, remote monitoring, hospital avoidance, long-term chronic conditions. Insert whichever one we want anyway. Hypertension is a nice logical one, isn't it? You can go everywhere. I think the ability to now leverage the solutions that we have implemented at scale for something else to act as that tool, and at the same time then develop how we have asynchronous communications with patients. And we've got a platform that enables us to do that, I think then becomes the key differentiator for Manchester. And I think it's something our patients will love. And then almost it becomes self-fulfilling because then they'll want more and more and more, and we'll want to provide more. So I think that for me is the key, is how do we change how our patients interact with their records? So instead of having, here's my blood test, I want to be able to sort of have asynchronous communication itself is terrific, but more importantly, just being able to have that contribution, the ownership, the empowerment. We've got 99% of all our women on maternity pathway are using the app, and we're using it for sort of care companion type services. We're pushing it an open door. And I think that's one of the things that we've sort of had that light bulb moment in the UK, certainly since COVID, in that actually that's now not what the public would like to have, and what our patients would like to have, it's what they expect to have. And therefore our differentiator is how do we make that as easy and as accessible and as empowering as possible? And then we just need to navigate that path with the national. But I think they would be my three: agentic, voice, and wearable ingestion.
Great. Well, I think we're going to spend most of the rest of the conversation going deeper into AI, but a gratuitous plug, so actually at Euphonia, we were literally mentioned at the last NHS England board meeting as the example of productivity through technology. And so just on that question about productivity, Randy, you're just about to go through a shift of your main EHR system, which I think is a pretty significant investment in all sorts of terms, and particularly financial. These are like large commitments that healthcare systems, and then we'll come to David, because I know you've been through the same journey as well. What's the productivity that you're looking to drive?
Well, there's a lot of components. First of all, right now, rethinking that something that experience is the new organizing principle, and sort of thinking about how can you help achieve that through the use of this tool, the EHR. But the EHR is really made up of a clinical platform, and in the US, a revenue cycle, or the commercial aspects or the reimbursement side of that. Second around that is that we think through the concept of the patient journey is our go-to-market strategy. And then third, we're now in the era, and I think sort of David kind of sets the stage on this. We're in the era where we now have clinical grade devices that are offered at consumer price points. And you do that as a 2x2, and you start to see kind of where opportunity can emerge, experience can be enhanced, and the like. Very important opportunities around the values and the investments that we make. First of all, the electronic health record is an essential platform just to sort of deliver and manage the complexity of what it takes to deliver care with large care teams in environments where we really want to drive highly empathic experiences for the patients, where we're delivering workforce improvements and reducing of cognitive loads for providers. So the more that we can sort of build into this integrated workflow, we can start to impact the patient's experience, helping the physicians drive a better outcome. But so I think number one of the most important things now, as you ask, is we've got to build capabilities that do not burn out the physician or the caregiver workforce. That, I think, is flat out number one of what we have to do. And these tools have the ability to aid in doing that. And then the companies behind them, as they sort of think about the design principles and what the capabilities are. And then on top of that, how do we then start stitching data together to start navigating and creating the patient journey and the patient story? Thus, the patient journey is our go-to-market strategy on that front. So just one sort of final point. I also find is that as patients, once they're sort of diagnosed, their specialty care kind of becomes their primary care. And right, they don't do anything without checking with their cardiologist, and they don't do anything with checking out these folks. So I think what's important is to become effectively voice engaged. And I'm going to lay out, there's sort of 4 things we laid out about 7 or 8 years ago. One of which is we started out and said, all care that can be digitally delivered will be digitally delivered. And we framed a second North Star, which was all care that can be delivered in the home will be delivered in the home. And third, as we sort of did this, sort of the key rep, is that we said all care will be conversational. And we've seen that come to play. But so what we want to do is we want that easy ability for whoever it is, being the caregiver, being at another sort of part of the workforce, the ability to engage with data and garner insights and ask questions and dialogue directly with data in a very natural way. We're also helping make better caregivers, better physicians, better workflows, better capabilities, better patient outcomes, better patient experience. So trying to make your question around sort of the value dimensions of those tools.
Can I just go slightly deep on one point you made with David? It's a really interesting point about like you're making this care more accessible. And David, and I obviously living in the UK system, primary care is a gatekeeper to secondary care. Maybe this is a bit of a controversial thing. Like, do you see the digitization or the digital accessibility is going to change that in the UK? Because suddenly, that gatekeeper role maybe gets eroded, or in a positive way, by the ability to access the people in your health system, David.
I think it will change, Nick. I don't think that's a controversial opinion. I think fundamentally the interface between primary care and secondary care in the UK model has never really been wholly effective. And then what we've done over the years is we've layered in a bunch of suboptimal tech in between those two. So actually, we put tech in that have made that worse. The way that the primary care refer, advice, guidance, triage, etc. It's just a clunky, suboptimal experience. So I think fundamentally the tech now can be improved on the interface layer. But the plans in the sort of 10-year plan, the vision for the NHS and that sort of left shift actually starts to challenge some of those pathway questions that we've had. Because to now, as an example, it's a primary care to hospital referral for hospitals to refer into a hospital at home service, for example. So there's a multi-step there to get to, in Randy's case, the North Star, the care is going to be provided at home. There's still a loop into hospital. Why can't primary care refer directly into the hospital at home service? What's stopping us enabling to do that with the right triage tools that can take place? Because actually that decision point. So I think we're going to change that interface anyway in the UK. I think it's going to shift. The neighbourhood model, which will be much more multi-agency out of hospital, I think will drive an expectation of then tech that leverages it. But if we take a step back to why doesn't it work today, in all honesty, I think it's the same way a lot of things doesn't work in as well as it should do in healthcare today, in that we've layered in lots of solutions to problems. We haven't taken steps out. So in effect, we've added to the perceived burden of that technology. And then at times, historically, that technology hasn't been good enough. And it creates that sort of perfect storm of no enthusiasm to use it because the tech isn't good enough. And then it actually just adds into that burden. I think that's, to Randy's point, sort of echoed with me. And when we talk about voice, productivity can mean a million things depending on which lens and optics we're looking through. But from a voice perspective, if I'm just talking outpatient clinic, the productivity gain we expect to see from that, at worst, means that clinicians will finish their clinic on time. And that in itself is enough of a selling point to get everybody behind that tech. We're not asking them to do admin in clinical time or stay late, etc. And that's before we get into actually it's using LLMs. And I know we're going to get into the AI conversation, but it's here. We're not talking 6, 9, 12, 18 months. It's here. It's here today. We have large language models, which by definition predict what's coming next in a sentence if you're using it for sort of text creation. We can develop those tools now within the right regulatory frameworks to predict what's going to happen next, which means that actually we can make sure that those clinics are filled with all the right patients for those clinicians to see, removing the burden of who's determined that they're the right patients to see, and then we can make them more productive when they're seeing them with the right tech stack. So you get this perfect storm at the moment, I think. And certainly, just to finish on the AI voice, I've been in digital now for 31 years, which feels a lot more and a lot less depending on which day it is, but 31 years. It is the first time in my career in healthcare and in private sector that I have people knocking on my door demanding that they have this technology.
Mm.
You know, we have to deliver this. There's no, and then it comes to Randy's point. We need to deliver it. We need to do it well. We need to do it safely, but we need to be, certainly from Manchester, I want us to be the first to do it, the biggest and the best to do it. And that's not from an egotistical perspective, but if I can achieve those holy trinity of those three, I get better patient outcomes, I get better staff morale and recruitment, and I get better experience. And that's the sort of objective measure of why we're doing this. So I'm really quite excited about where we are now.
Yeah, I mean, look, it's a great time to be alive in terms of the technology. Just to take it personally, what are you each finding like at the moment? You know, the space is moving super fast. What tools like have caught your attention recently? Do you use? Do you find personally productive and exciting?
I mean, personally, for me, I'm not even ashamed to admit it. I can't live without Copilot now. For me, from a personal perspective, just from my researcher perspective, I don't write papers with it. I haven't quite got to that level yet. I feel a bit of guilt still by spitting out an AI-produced paper, but the researcher and agent side, just quickly market testing, things which previously I would have gone to sort of analyst groups to get papers, I can now sort of produce that information. I don't go a single day without using Copilot on a sort of, on a personal level. I think the thing that gets me, we've got a whole raft of AI, and let's be honest, most of it is rebranded maths, and some of it isn't as great as it's sold, etc. But there is some really terrific AI out there. I think the bit that gets me most excited is the AI now that can do the sort of risk stratification, predictive modeling of patients much better than the old predictive models, which was, well, we saw this many historically over this pattern and therefore we'll skew it for seasonality, etc. To get that assurance now that we're seeing the right patients in the right order and the right triage, and then we layer over all the diagnostic stuff. And your solution, Nick, Euphonia, which you know, as you know, I'm a great fan of, and it's brilliant to see where you've taken that product over recent years. But that's a great example because your product essentially is yours is a product productivity piece because you're removing the human burden of having to undertake that conversation. And that's therefore, to my North Star is, I want to rewind all those layers that we put on and never taken out the steps. I want to now take the steps out, whilst at the same time, just improving what appears in front of the precious time that clinicians get in the system. So, but personally, it's Copilot. I generally can't live without AI.
I mean, I can't live without Claude. I'm addicted to the productivity that it generates. Randy, obviously, same question to you, but maybe could you also take us down the direction of, like, these tools are so amazing, what they can do is so great. Could you take us into the buy versus build discussion, which is always a dilemma for CDIO, CIOs, but in a world where these tools are able to generate things that would previously have taken months, if not years, of single companies to build. Like, so what are you using personally, and how are you thinking that buy versus build decision is going to change, if at all?
Let me start with the sort of the way you framed the question first, just around, we see these tools building on what David said, but what we want is conceptually right case, right place. And so, like, we think that the AI can help us figure that out about getting the right case to the right place, which is effectively getting the right care, the right time, the right form factor, the right location. On the tools, I do find, and it's amazing, right? At one point a few years ago, none of us knew these, and now we can't not use them 20, 30, 40 times a day. I think the productivity leaps are quantum in terms of the impact. I do find the framing of the technologies, the spaces where we can help solve problems around ambient listening and ambient documentation. We've also created a new role in healthcare that we call the inboxologist. And that allows, how do we help those clinicians who have now this other sort of vehicle or this route or this pathway or this vector to interact with between the patient and the provider's office. And every morning they open up and they've got a handful of things sitting in the inbox. We need someone to sort of go through them. So we think we can navigate the the inboxologist and ideally replace them with the AI to do that. And then, then the question, the AI still operates under the license of the clinician. So Nick, I think I got half your question. Maybe I could ask you to reframe the...
So the other half of the question is, these tools are creating the ability for people to multiply their effort and recruitment into healthcare IT roles. Even in the US, I guess, Randy, where you're able to pay a little bit more, you can be, but in the UK, I guess, it's quite a tough, role to fill because of the sort of competitive position. But suddenly you've got people who can do way more than they used to be able to. Does that change your calculus about whether you can develop stuff in-house versus having to buy it from external vendors?
Let's start out with sort of a framing I have on this, which is organizations have vital functions and core competencies. Sort of stepping back and figuring out here, if I need to solve a problem, does it make sense for me, in this case, first I want to determine, is this capability a vital function to my organization? And does it need to be a core competency? If it needs to be, if it's a vital function and a core competency, I need to basically think about, can I get what I need through a contracted relationship? Is the market moving so fast that I can't invest and keep up with? And those push me all in the direction of buy. So
still, yeah. Okay. It's interesting. David, do you think, it's chronically difficult to hire in IT roles in the NHS. Is this going to help?
It's just a competitive marketplace, isn't it? But for fear of a conversation where we're both in vehement agreement, I can't disagree with Randy's point. I can't see a logic. No, there's no two cases the same. So, I'm being generalistic. But my default position must be now that I'm not a software provider. So there may well be sort of niche problem statements that I'm trying to fix, connect this to that or do this to that sort of thing. But it's got to be buy, not build. And I think what's really interesting in the market, I don't know whether you saw there was a piece this week without naming them, but one of the big four consultancies in the UK who have actually demanded that their internal auditor, who is one of the other big four consultancy in the UK, charge them less this year because they're using AI. So actually the buy market conversation is shifting also. I think it's, but logically it is competitive. I just don't want to be a software house. And also by the time that tech stack is moving at such a pace that, I had this dawning realization last week that there isn't a single piece of technology that I trained and built my career on that's in existence anymore. But that took 10, 15 years to get away from the sort of tech stacks I was built on. You're talking 3, 6, 9 months now. So actually, I think it's got to be a de-risk model, and therefore you default to buy, but don't close the door when you need to build.
This is a super interesting reflection from both of you, because I think that's very much counter to, I guess, the financial markets narrative in the past few weeks, which has thought that the new models that are coming out of the hyperscaling companies are going to mean that everyone is a software developer. But I think what you're both saying quite clearly is in healthcare, there's something slightly different, right? In terms of being able to have some assurance around it. Is that fair? Is that the right framing?
Well, from my perspective, I don't know what the regulatory compliance is in the States, but I think, and it won't just be healthcare, will it? There'll be other industries that are highly regulated. I don't think that stacks up in the regulated. As I say, it's not binary. It's not one or the other. I think it probably is a combination of both. But the dominating majority would be buy. I feel, not fear.
We don't see this or look at it as implementing software. That may be changing by software writing software. But what I really see is that we're enabling new organizational capability. So as we further drive on that, and then there is no way that my organization is going to be able to absorb at the speed of the information being generated around these tools. And so that further reinforces my ability to remain competitive. I need to sort of take that same market position and buy the product and keep speed with market. The question then becomes, is how do I leverage that buy into something that's competitively differentiated on the dimensions which are important to my stakeholders, my customers, my patients, on all those dimensions? How do I outcompete? That came back to my point where you need to be a faster problem finder, because everybody gets to that implementation starting line. They're all starting with, in theory, same access to capital and can make the same investments. So how do I then competitively differentiate? And that becomes the core where we can then direct and focus.
I think that's a really great comment. Just maybe could you just, we've got seeing a lot of similarities. The regulation is just one point where there may be some difference. I don't know whether you'll have both seen, or Randy will have seen in the US. There was some news in the last couple of weeks about a company up in Utah, I believe, that is prescribing or is being, prescribing autonomously, and maybe skirting some of the regulatory approaches. Do you feel in the US there's a more permissive environment for regulation around healthcare AI, or has nothing much changed?
No, I think the environment is moving and changing fast, and the administration are working to sort of how to embed more digital capabilities and doing other things like extending hospital at home capabilities where we're able to sort of deliver services through technology where we can make the investments and we get reimbursed at a rate that effectively allows us to be a sort of a sustainable billing approach. And we can then further invest, tools, platforms, and enterprise. So I do think that it looks like there's a kind of a maturing, a flexing environment in the States. I am not a policy expert or a deep policy expert, but I am always amazed when I sit in a room and get a policy briefing from some of these brilliant folks out there. And you come away a little bit smarter on that front. So predict, I'm not going to predict, but will become more permissible. It feels like that's a gateway to helping increase access while still putting it forth the patient safety, the benefits of doing this work. And what if you didn't do this work? What's the outcome on that end?
Just one more question around the new technologies coming into the systems that you're working. Randy, you've literally written the book about how vendors, I guess smaller vendors, should interact with the CDIO of multi-billion-dollar health systems like you both are. Have you got any thoughts about that in general? I mean, again, does it change in an environment where the pace of change is accelerating?
I'll start, David. I think for those firms, the way to get access and to help demonstrate value in a way that's contextually relevant to the sort of the unique problems that I have, and then problems at certain levels, the industry challenges, my organizational challenges, my provider challenges that we have to do on that front. So I think there's always going to be a selling apparatus that has to exist. And the question is, can you demonstrate? So here's an interesting thing I was thinking through. I was having a conversation the other day, and we talked about like we're piloting some new capability. One of those big challenges, if you taking a pilot, we can either say, let's do 100 pilots and see what sort of, spread the seeds and see what germinates, or do we do a small handful of highly targeted pilots? Because one thing we're going to obviously at some point conceivably scale, but when you're doing a pilot, there's a point at which if you really run it as a controlled experiment, and like you may have folks in your organization say, I'm finding benefit from this. And we may turn out and say, well, we're going to decommission and we're not going to scale with this, maybe for other big reasons. So you've got to sort of build and understand that value proposition and make that commitment. And when you make that commitment, you need the technology provider by your side, helping you basically extract the value on their tools and their platforms. So,
David, it's often said that the NHS has more pilots than British Airlines, but I know, have taken a relatively early stage technologies and then scaled it, which is the real challenge. Any thoughts about like how that's done effectively and what the need is from your perspective?
Well, so I think I'll be blowing my own trumpet with regards to effectiveness, but I'll do it anyway because I've got a captive audience. I think certainly in the UK piece, but to Randy's point, I'm going to actually just reverse back a moment. I think Randy just hit on something which is the actual central point of this conversation. It's got to be, the conversations have to be around what problem and at what level of the organization problem does this fix, rather than what solution does this provide to a particular outcome piece. I think too many small providers start with some of them have beautiful products, but if it's not answering a problem that I've got, sort of outcome-based problem, then we've got to, there's going to be a challenge before we start, because essentially I've got only a finite amount of resources to be able to purchase. So I think there is, and I think that is maturing in the UK, actually. I think those conversations got better. I think, and a lot of it are driven, actually, I think the entrepreneurial drive now is more clinical-based entrepreneurial. So actually it is more focused on specific problems. So I think by nature of the market, the conversation's getting better. Then I think it's around organizations. So we're doing it in Manchester we've got a sort of innovation program called ITAP, so a sort of innovation transformation program, where we're going to slightly change it next year, because up to now we've gone to market, found a bunch of solutions that we think that looks good. Most of it is early stage, some of it's even pre-seed type stage. And then we've sort of triaged that through, which priorities does that fix? Is it cross-clinical? Is it vertical clinical, etc.? And you put it through the machine and you come back and we take it through a process, much like we had, as you'll be familiar with, Nick, in Oxford when we had the Hill. And we're getting some really good success out of that. And some companies there are able to sort of prove their pilot in Manchester and then take that to market afterwards, if nothing else, with relevance with regards to large-scale deployment and testing in healthcare. We're going to change it slightly next year. So actually, we're going to go to the market and do that horizon scanning on what are the 6 things that we need to have as a hospital, rather than what is completely out there. Because I think we've probably taken too much in to take through the triage. So actually, we're filtering more out than we can concentrate on. And I'd rather have fewer, more impactful pilots than large ones. And there's a sort of trade-off to make there, isn't there? Especially if it's sort of, depends on what the commercials look like, but if it's about an equity conversation versus a purchase conversation. So it's, again, a bit of a trick. But I think the key is the scale afterwards. This is what we don't do well in the NHS, because I will find a solution in Manchester and go, this is brilliant, this is great, thank you very much. How does that then get to market? Because it's still a small provider. It's not going to go on the large procurement frameworks that we have to go through from a UK perspective. But I think the structures that we put in are counterproductive to innovation at scale. The regulatory framework, which may I say is getting much better, I think there is some really great directions of travel changes being signalled by the MHRA, NICE, etc. on this. But the idea that I have to go through a process and tick and prove the information governance and the safety and all those sort of things here, and then another hospital needs to go through all that again. It's a 1,000 flowers bloom approach with regards to innovation. I think those shifts in the regulators are really, really positive. We've got the AI review taking place at the moment, central government. I think that outcome, that new framework will be great. But we do not scale well. And I think this is where we need to use the innovation networks, the AHSNs as they used to be in England, but the sort of health innovation networks. They're the vehicles that are naturally there to provide that scale. So it's not my job to be a scaler of somebody else's technology, but we have innovation services there to do the scale. And I think once we can make that join up between the different accelerators that are here, so ITAP in Manchester, the Hill in Oxford, the great ones in London, when we can link those into we found a solution scale and the regulatory compliance, I think we will fly in this country, because there is dozens and dozens and dozens of brilliant companies out there that just need to prove that they're brilliant. And we need to take more of a risk-based approach to the testing of that. And I think that's a regulatory change that the MHRA is signalling.
Yeah, great. I mean, we're sort of drawing towards the end of the conversation. Before I'm going to finish by asking you about where you see the future opportunities, what you're most excited about. But just one step before that, technology is fantastic, right? But if I could suggest, your role is as much about the people as the technology. Randy, we talked about the fact that you're about to go through a big EHR switch. How do you see your role in terms of that transformation and the people side of technology? What's the secret sauce here? How do you do that well? Because that, in my experience, is always the biggest challenge, is getting people to change what they do or approach things differently.
I think David and our roles could be chief change management officers. This role is about helping move people from where they are today to where we need them to be by helping paint a vision in a way that they understand, helping bridge sort of a platform to help them sort of play a role in shaping how we get there. And we know that we want to encourage people to come and participate. If your voice isn't heard, others will speak on your behalf. And so it's important to drive that engagement and creating a sort of pathway under which, when we have what feels like disruptive technology, and sometimes non-disruptive technology, can be sort of concerning or threatening, or people may feel a disconnect with it because it might be, making life challenging in a different way, or they might lose their ability to use the tools that they were comfortable with. So a lot of time spent pressing the flesh, listening, talking about abstracting the technology away, thinking about what's the purpose of the work and why we all chose to do this work. So it's a lot of that. It's real culture building work. It's, and it's on an individual by individual basis, an organization by organization, and the like. And I think high functioning CDIOs understand that. And then, what are the upsides to this? And I think through that with people, one of my sort of things I'd love to share with folks is say, good decisions with AI are now great decisions. And especially as you add layers of complexity and layers of data, it's beneficial to the AI, but it's a hindrance to human beings. And so if we can empower you to do your work and amplify you, listen to what you have to say, adapt the tools to help people do the work that they need to do, we will be successful in navigating that change.
And David, any practical tips from the top, from the biggest health system, in the country about how to support that change?
Well, to be patient, I guess, would be my number one tip. I think, that's the thing. That I see our roles as a sort of architects of healthcare reimagined. And by that, I mean, we're going on a journey across healthcare, across the world. The challenges are universal. We've got staffing won't keep up with demand. There's a fact. Demand is only going to go one way fundamentally. And we need to move to much more preventative, because actually the prevention is a more cost-effective model than cure. So I think those challenges are universal. We've gone through a process of that analog healthcare model to digital, with all the challenges that then brings when we're navigating the old way to the new way. And I think we're leading that change, that architecture, that navigation. Where I get excited about is I think in the future, and I don't know where that reflection point's going to be, I would say by the end of this decade, probably, I think the technology curve will be such that actually we're not talking about analog to digital. We're redesigning healthcare from digital back. So, and working backwards on that equation, but holding central to the premise, it is the most humanized profession in the world. And we don't want to lose that experience piece. But what I want to make sure is I've got my highly trained nurses and doctors and AHPs and care professionals with the right tools, with the right patients. And I think that's the shift that's going to happen. And I think the model of care will change. It will have to change because there won't be enough staff. Yep. And therefore, these conversations won't be about transformation. It'll be about core. That will be the primary route, and we work backwards. And I think that's the reflection point that's coming. And I get both excited and conscious that if we get this right, it's going to be wonderful for everybody. If we get it wrong, it's going to be the opposite of wonderful. And that's the bit that I get excited about now, because I think this is.
So again, slightly controversially, we've written about how I think it's necessary for us to get ahead of how we're going to regulate technology as a professional or a form of a professional. Does that mean that you in the future are going to be sitting alongside the chief medical officer of your organization? You're responsible for the AI doctors and they're responsible for the human doctors?
Well, there's a controversy. I'm probably not going to commit to this. I don't think I will. I think this is maybe next stage career. I think I'll be retired by that point, Nick. But I think
very diplomatic.
It is. Well, but I think if you look at it just from a unitary board perspective, as a sort of executive team of MFT, I think this is the thing. The hospitals in the UK that get it because there is a strong voice guiding and advising the board. And the board also don't consider digital as an add-on function. It is there to the core delivery. That's why they're around the executive table. I think, therefore, it's less about responsible officer for this doctor versus that doctor, and more about actually collective responsibility for the outcome of our patients. And I would say it's not one or the other, but you can't remove digital from the cake mix now. It's in. So therefore, it becomes equalizing. So I wouldn't say we'll get regulatory responsible officer status in this country, nor would I want it, nor do I think I'm qualified for it, most importantly. But I think the narrative will change. It will fundamentally shift and change, and the conversation will change. And professional regulation will change also, I think.
And so again, just to finish, so Randy, what are you most excited about? What's the big bet? What's the thing that's going to really change for you in the coming handful of years?
That's a great question. There's a lot that's going to change. I'm going to give you the example that just popped into my head, which is something I said at the beginning about conversational AI. So we've worked with an outside partner to develop a capability of conversational avatars in our radiation oncology space. And those are effectively like deep fakes, if you will, for good. And the ability to then, in the States here, patients have to have, they're taught certain things about their radiation oncology, and they have to then do teach back and say, this is what I heard from you, and they teach back. We built a capability that allows the conversational AI to take place between the patient and the avatar, and we've duplicated their voice. So when you go online, you have this conversation. It is with an avatar doctor. Your doctor may be asleep in bed, and you may have said, "Oh, I really have some questions, but I don't want to bother the doctor." Or your spouse or significant other didn't have an opportunity to participate in the conversation. So at 10 o'clock at night, 7 o'clock at night, they can fire up the computer, log on, and have conversations with the clinician. And it may be, will I feel a burning sensation? How long will it last? Do I have any permanent damage? All these questions that will then be answered. So I'm really excited about how this conversational AI will really empower patients. I mean, talk about the agency that you return when people are like, I don't want to bother the doctor. And so then you think about the load we take off the doctor in terms of having to re-explain all of those things, and the fact that you can unlock and do that anytime. So I think the thing I'm most excited about is agency back to the patients through AI.
Great. Perfect point to end it on. I think we're all super aligned on the fact that we can massively scale the access to healthcare through these sort of technologies using these type of approaches. So thank you both. Wonderful conversation. Lots of commonalities across the Atlantic as ever. Lots of exciting opportunities for us all going forwards. Thanks again. Well, that was a great conversation. A lot of the themes relate to what we do at Euphonia in terms of automating healthcare using technology, AI specifically. If you'd like to learn more about that, please go to our website or just contact us and we'll be happy to get in touch and speak to you about what we do. If you like that conversation and would like to hear more, please subscribe or listen to our podcasts on Spotify, Apple Music, or even watch them on YouTube. We'll have more content coming up there in the coming weeks and months ahead. Thanks very much.